This presentation will be reviewing the problem of rising HIV and hepatitis C rates within the City of Ottawa, Ontario, and the concept of supervised consumption facilities as a way to address the issue. Within this presentation, we will cover the pertinent health issue of HIV and hepatitis C within the marginalized population of illicit drug users in Ottawa. The reasoning for why this is such an important health issue will be presented, followed by a deeper exploration of the issue and this population of interest, with relevant facts and figures provided, as well as an outline of available options for action. A brief overview of the intervention wheel model for population health. The model chosen to address this health issue will then be presented, followed by specific recommendations for the implementation of supervised consumption facilities, SCFs for short, as an effective way to address rising HIV and hepatitis C rates in Ottawa. The incidence for HIV and hepatitis C among people who use drugs in Ottawa is alarmingly high. In fact, the rate is one of the highest in Canada. Among people who inject drugs in Ottawa, surveyed in the fall of 2012, 1 in 10 injection drug users were infected with HIV, while 7 in 10 had contracted hepatitis C. This is a very important health issue, not only because of the high risk of transmission of these communicable diseases, but also because of the mortality rates associated with them, not to mention the exorbitant costs to our already overburdened healthcare system each new case of disease presents. The average treatment cost of a new HIV case is approximately $211,000 per year, and the treatment cost for a new hepatitis C case is $35,000 per year. That adds up quickly. HIV and hepatitis C incident rates have remained high and continue to climb in this population of interest due to the fact that people who inject drugs are seen as a population that is hard to reach with conventional public health strategies due to a number of complex barriers such as treatment-related costs, transportation issues, stigma, and discrimination. Additionally, these people possess a limited knowledge of available services, face long wait times and limited hours of service, which result in an over-reliance on costly emergency services and the tendency for this population to have unmet healthcare needs. In Ottawa, 1,200 to 5,600 individuals were estimated to inject drugs in 2008, and in 2012, 43% and 73% of diagnosed HIV and hepatitis C cases involving the injection or inhalation of drugs reported sharing drug equipment such as needles. Alongside elevated HIV-related mortality, drug overdose is the most common cause of death in this population, resulting in approximately 115 hospitalizations and 40 deaths in Ottawa annually. The evidence in support of SCF speaks for itself, yet we still have options for action in addressing the issue of high HIV and hepatitis C rates in Ottawa. These are to maintain the current harm reduction initiative of the needle exchange program in Ottawa and make no other policy-related changes, to refocus efforts and resources on treatment aimed at abstinence from drug use and enforcement of drug laws within the city, or to implement a supervised consumption facility for safer injection drug use. In consultation with the existing literature, and in my professional opinion, it is recommended that the city begin working to implement a supervised consumption facility immediately. While there remains a debate about whether or not SCFs are the best way to address this health issue, there is a lot of evidence in support of this intervention for the best long-term outcomes in this population of interest. Using a harm reduction approach, such as an SCF, first addresses the conditions of addiction and stigma that deter people who use drugs from conventional care and empowers them to take control of and improve their lives by rekindling their sense of self-worth. Here is some more evidence in support of SCFs. SCFs achieve desired outcomes. They allow for more direct and timely contact with health and treatment services while lowering the occurrence of overdose fatalities, public injection drug use, and infectious diseases. SCFs achieve more than the desired outcomes. They also lead to an increase of referrals into detox and drug treatment programs, as well as counseling, primary healthcare access, and housing supports. The public is in favor of SCFs. Public opinion towards supervised consumption facilities in Ontario shows that a majority, 56 versus 38%, is in favor of the Canadian government establishing more SCFs. The target population will actually use SCFs. Up to 75% of people who use drugs in Ottawa said they would use an SCF, with those most likely to report they would use one being people who are at greatest risk of contraction of HIV or hepatitis C, those who are unstably housed or live on the street, and who are unaware of how to access sterile equipment. Lastly, SCFs are financially advantageous. Looking once more at Vancouver's insight, it prevents on average 35 new cases of HIV and almost 3 deaths each year, which equates to a societal benefit in excess of $6 million per year after the program costs are taken into account. Preliminary research projects that the opening of an SCF in Ottawa could prevent up to 10 new HIV infections and 35 new hepatitis C infections per year, resulting in significant cost savings. The cost of operating an SCF in Ottawa is an estimated $1.5 million, while as previously mentioned, the average treatment cost of a new HIV and hepatitis C case is almost $211,000 and $35,000 per year, respectively. An SCF in Ottawa would therefore result in net savings of at least $1.8 million per year in Ottawa. Here you can see the mathematical breakdown of the net savings gained by having an SCF in Ottawa. The last part of this presentation will present the intervention wheel as a theoretical model to be used in the implementation of an SCF in Ottawa with accompanying recommendations. The intervention wheel, previously known as the Public Health Intervention Model, was originally introduced in '98 by the Minnesota Department of Health and has since been widely disseminated throughout the U.S. It is a population-based practice model that encompasses 3 levels of practice: systems, community, and individual family, and 17 associated public health interventions. Each intervention and practice model level contributes to improving some aspect of population health. The intervention wheel model chosen as a framework for the issue of rising HIV and hepatitis C rates in Ottawa because of its focus on intervention at various levels of public health practice. The main proposal to address this health issue is the implementation of a supervised consumption facility in Ottawa, which is an intervention-based approach to reducing HIV and hepatitis C transmission rates among the population of interest. The implementation of a supervised consumption facility in Ottawa would involve action by public health nurses at all 3 levels of intervention. System-focused practice changes, organizations, policies, laws, and power structures. An SCF in Ottawa will require new policies and legislation that make it possible for people on the facility premises to safely inject illegal substances without legal persecution. This will involve advocacy and policy development and enforcement. Community-focused practice changes community norms, attitudes, awareness, practice, and behaviors. It is directed toward entire populations within the community or occasionally toward targets grouped within those populations. A supervised consumption facility will require a shift in community attitude toward the facility and the population utilizing its services. This will involve collaboration, coalition building, community organizing, and social marketing. Individual-focused practice changes knowledge, attitudes, beliefs, practices, and behaviors of individuals. This practice level is directed at individuals alone or as part of a family, class, or group. An SCF will target individuals within the population of injection drug users with aims of encouraging lower risk behaviors surrounding drug consumption and sexual behaviors, such as using sterile consumption equipment, not sharing equipment, and using condoms during sexual encounters that lower the overall risk for HIV and hepatitis C transmission. This will involve outreach, health teaching, counseling, referral, and follow-up. To maintain the efficacy of the intervention and to evaluate its effectiveness, surveillance, screening, consultation, and collaboration will need to continue taking place in a cyclical fashion that follows the nursing process in a public health context. Specific recommendations for the implementation of an SCF include the following. SCF implementation should begin with a pilot project involving one SCF in Ottawa with a comprehensive evaluation plan as the first step towards implementation. Surveillance activities in relation to health and other outcomes should also take place and should be publicly disseminated. In addition to supervision of injection of drugs by trained health professionals, the SCF in Ottawa should aim to provide additional services such as nursing care, hygiene services, counseling, detoxification, social services, overdose prevention and education, equipment distribution and disposal, referral for drug treatment, mental health services, basic medical care, wound care, vaccinations, and testing for bloodborne infections and pregnancy. FCFs should be partnered with other agencies that currently serve the target population, such as the Needle Exchange Program in Ottawa. Integration and close linkages with existing organizations offering a broad range of services will ensure that FCFs provide access to needed health and social services, but do not duplicate what is already available while already having an established relationship of trust with clients. Lastly, the financial resources required to operate a supervised consumption site could be diverted from the provincial hospital healthcare budget, as such harm reduction program would be saving costs associated with treatment of HIV and hepatitis C cases, which are currently paid for from the provincial hospital budget. It is therefore clear that the population health issue of elevated HIV and hepatitis C rates among the marginalized population of people who use drugs in Ottawa can be best addressed through the implementation of supervised consumption facilities. While recommendations are made above for the initial implementation, it is hoped that as data regarding the effectiveness of the SCF program is obtained, services are expanded in the form of at least one additional supervised consumption facility in order to better address climbing incidence rates of HIV and hepatitis C in this population of interest.